So today we are going to cover the surgical anatomy of the liver, and we will cover the neoplasms of the liver. The other parts that I was given, so pyogenic abscess of liver and hydrated cyst, if I go through all of them, nothing will actually be learned. So I will just cover the surgical anatomy, which is very important, and we will cover the tumors of liver. So in your anatomy classes, you have learned that liver is divided into two lobes. One is called the right lobe and one is the left lobe, and this is what stays in between, that is the falciform ligament containing the ligament of teres. But you need to unlearn that thing from now on, because we have cursed the anatomy. This is the anatomical division and this is the surgical division. So here the falciform ligament is there. As you can see in the anatomical divisions, the right lobe is much larger than the left lobe. The liver tissue in the left lobe is smaller, much smaller than the right. But the surgical division, there are actually three things you need to remember. The first division, the second division, and the third division. So on the basis of that, we name them, and these names are internationally recognized, so you will not change the names in any other way. So the first thing, we divide into two hemilivers. The liver parenchymal tissue is actually divided into two identical parts, right hemiliver and the left hemiliver, by a plane, midline plane. You know, the pictures that I am drawing here is a two-dimensional picture. But if you have seen the pictures there in the specimens of liver, where you can see that it is a three-dimensional structure. So it is a plane. Plane means it's just like not, it will go through the entire depth of the liver tissue. The plane joins the gallbladder fossa with the inferior vena cava. This is the line of surgical left lobe and right lobe. And each lobe, you have learned in the porta hepatis, there are three structures. One is the bile duct, one is the hepatic artery, and the other is the portal vein. So the first division is actually contain all three of them. That means they have their independent arterial division from the right hepatic artery. Right goes to the right lobe, left goes to the left lobe. Similarly, they have the same ductal drainage, draining the bile, right duct from the right lobe, left duct from the left lobe. And so does the portal vein, one for each. So the first division, that is divided into two hemilivers. Suppose if I do a surgery and remove this part of the liver, that is called right hemihepatectomy. If I remove the left lobe, that means that is called left hemihepatectomy. You must understand that we have been given an enormous amount of reserve liver tissue for us to survive. Theoretically speaking, if I divide the liver into 8 parts, which are actually do in surgery, ultimately the third division that I have written, there we will go into something that are called segments. So the first is called lobes. Third is called the segments. They are from 1 to 8, of which, that means if we have divide the liver into 8 segments, if we have one segment, functioning segment, healthy segment without any disease, that is good enough for us to live a normal life. And that is why orthoptic liver transplantation is very handy. You can get one donor liver and you can actually transplant it into more than 3 recipient liver transplants. So unlike kidney Kidneys you cannot divide and transplant it. So the first division is based on the entire portal tract. They are called lobes of the liver. Surgical lobe starts from inferior vena cava to the gallbladder fossa, and this line has got a name. Cantlie', Cantlie's line. You must remember that, that will be asked. So it goes from the left border of the inferior vena cava to the gallbladder fossa. It is not mentioned which word, but it is just into the gallbladder fossa. This is the surgical lobe of the liver. So anatomical lobe, whatever you have learned, you should unlearn that thing. That is no longer there. So the second division that we do, that I cannot draw it on a picture, that I am going to show you on a picture there, because it is a three-dimensional thing. This is, as you can see, this is a three-dimensional picture. That means this part is in front and that part is behind. So here we divide each lobe into two different sections. So the second part, second division is called the sections. অনেক সময় এটাকে sectors বলে. So sectors. Here the distribution, based on the distribution of the bile duct and hepatic artery, which are symmetrical on both the sides, but portal vein is not symmetrical between the right and the left because of the embryonic venous circulation থাকে, some part of it stays. So here the distribution is based on the symmetry of the bile duct and hepatic artery. Earlier it was all three, now it is two. So these are called sectors. So right sector is divided into two sectors. One is anterior, the other one is posterior. So right anterior sector, right posterior sector. এই প্রত্যেকটা থেকে sectorial duct একটা করে বেরোয়। Right anterior sectoral duct, right posterior sectoral duct দুটো মিলে তোমার right duct হয়। So second level of division, we get two each. One is called anterior, right posterior. Similarly, the left one is not called anterior and posterior, they are called medial and lateral. So here you can see there, এটাতে তোর এটা হচ্ছে lateral, এটা হচ্ছে medial। ঠিক আছে, তাহলে left এর lateral, medial, right এর 5 আর 8 হচ্ছে anterior and 7 আর 6 হচ্ছে posterior. And the third division, they are called the segments. You know, the liver has been segmented and it was discovered by Couinaud. So that has changed a little bit, but more or less the stays like that. It has got 1 to 8. 1 to 8. One is the caudate lobe, which is not mentioned here. One is the caudate lobe, that is there, this part. And 2, 3 is the left lobe lateral, 4 is the left lobe medial, 5 and 8 right anterior, and 6 and 7 right posterior. এখানে যেগুলো লেখা আছে না, দেখ এটার মধ্যেই তুই সব এটাতে, এই যে এটা দেখতে পাচ্ছিস, এটা রাইট হেমিলিভার। হেমিলিভার মানে হচ্ছে এখান দিয়ে ভাগ হয়ে যাচ্ছে। সো দ্যাট ইজ হেমিলিভার, ইনফিরিয়র ভেনা কেভা থেকে। এটা হচ্ছে পরে আমরা হেপাটিক ভেনগুলো পরে আলোচনা করব। বেসিক্যালি রাইট অ্যান্টেরিয়র অ্যান্ড রাইট পস্টেরিয়র যে সেক্টর আছে, এর মাঝখান দিয়ে যে ভেনটা যাচ্ছে সেটা হচ্ছে রাইট হেপাটিক ভেন। দ্যাট ডিফারেন্সিয়েটস বিটুইন দ্য রাইট অ্যান্টেরিয়র অ্যান্ড রাইট পস্টেরিয়র সেকশনস অর সেক্টরস। ঠিক তেমনি মিডল হেপাটিক ভেন যেটা আছে, এই মিডল হেপাটিক ভেনটা যে আমাদের রাইট অ্যান্ড লেফট লোব যে দুটো ভাগ করেছি, সেই দুটোর মাঝখান দিয়ে যায়। So this one also based on bile duct and hepatic artery. এই hepatic artery distribution তোদের পুরো জানতে হবে, কোথা থেকে অরিজিন হয়, কি কি anomalies থাকে, that you need to read little bit regarding the hepatobiliary surgery তে আছে। So this is the new lobes of liver. তো অ্যানাটমিতে যেটা পড়েছিলি ওটা একটু ভুলতে হবে তারপরে so there are 8 segments, 2 lobes, each lobe has got 2 sectors or sections. These sections has got independent arterial supply. You know, liver has got dual blood supply. One supply comes from the hepatic artery, the other supply comes from the portal vein. But the distribution is made on basis of the supply from hepatic artery. The right anterior sector is supplied by right anterior sectoral artery, which is a branch of the right hepatic artery. Okay, so that's done. Now we are going to go into the liver tumors. এর মধ্যে তোদের benign liver tumors-টা কেউ পড়ে না, ওটা থেকেই শর্ট নোট আসে। Benign liver tumors. Most common liver tumors is secondaries in the liver. That means metastasis in the liver from any cancer, stomach cancer, breast cancer, lung cancer, anything. So that is the most common tumor. However, initially we will start about 3 benign liver tumors. The first one is hemangioma. It is the commonest tumor. It is so common, it is present in about 20% of normal humans. So if you do scanning, these hemangiomas will be there. The size of the hemangioma varies. Significant size, we call it when it is more than 5 centimeter. And in all these benign tumors, there is a definite gender bias. Hemangiomas are common in women, much more. The ratio is about 3:1 between female and male. And there is always a relation to the estrogen receptors. Sometimes estrogen receptors have actually been found within the hemangiomas. So these hemangiomas are known to suddenly increase in size whenever the blood circulation of estrogens is high. That is during puberty, during pregnancy, and also in males who take androgenic steroid drugs. So they are likely to suffer from rapid increase in size of the hemangiomas. Now these hemangiomas are not actually a tumor. They are a bit of an hematomatous malformation. So they are not tumor, but they are definitely like any other hemangiomas. They are also compressible. What are the risks of this hemangioma? 2 things in all these 3 you need to, the examiners will ask, or during long case you need to mention about 2 things. One is the chance of malignant transformation. আর 2 নম্বরটা হচ্ছে spontaneous bleeding. এই দুটো জিনিসের উপরেই এই তিনটে তোর benign disease hinge করে. So hemangioma, even if they can become large, as large as 20 centimeter in diameters, but hemangiomas are not known to cause spontaneous bleeding. So it doesn't cause spontaneous bleeding even if the tumor grows to the size of 20 centimeter. And the chance of malignant transformation is 0. So what should be the treatment of this patient? As you can see, they are frequently found as an incidental finding during many scanning, either ultrasound scan done for other reason. The treatment is expected line. That means we do not surgically intervene even if the tumor is more than 5 centimeter. Because it does not transform into a malignant tumor, neither it bleeds. However, one thing can happen, because hemangioma contains many large dilated vessels. Sometimes what happens, they consume a lot of coagulation factors and platelets. So when those hemangioma actually consumes lot of blood coagulation factors and platelet, then what will happen? The patient will develop a tendency to bleed, and that is known as some kind of syndrome that is called Kasabach Merritt, RRITT, Kasabach-Merritt syndrome. This is a complications of hemangioma of the liver. It is because of the excessive consumption of coagulation factor and platelets. So surgical intervention is not required. And one thing you should never do, how will you diagnose? The hemangioma is very easily diagnosed on ultrasound. However, if you want to confirm the diagnosis, then you will have to do a multiphasic CT. Whenever you do mention about CT scan, in case of a liver tumor, you mention it is called multiphasic CT. Multiphasic CT means এর একটা ইনিশিয়াল আর্টেরিয়াল ফেজ থাকে, early arterial phase and late venous phase. Venous phase মানে portal phase. So multiphasic CT, there you will get an early and uniform enhancement of the tumor, and that actually confirms the diagnosis of hemangioma. One thing you should not do in case of an hemangioma is never to ask for a FNAC, because you know in CT guided or radiology guided FNAC, it is the FNAC. If there is a hemangioma, if you do a FNAC radiologically guided, that can bleed very profusely, and that is the only indication when surgery is to be done. Surgery, when it is done in the setting of a severe intraperitoneal bleed from an attempted FNAC, is usually takes the form of a resection. Resection means hepatectomy. If it is involving in the right part, you will have to go for right anterior sectional or right hepatectomy, hemi-hepatectomy. You understand? So this is hemangioma, of which we remember it is not exactly a tumor, it is an hematoma. It is the commonest. Incidence as high as 20%. It does not change into a malignant tumor. It does not spontaneously bleed. Surgically significant hemangioma is anything more than 5 centimeter in diameter. Hemangioma can be very big. Big hemangioma can cause a consumption coagulopathy, causing bleeding because they consume excessive coagulation factors and platelets. That's called Kasabach-Merritt syndrome. And how will you diagnose? Ultrasound is very good, but its specificity is low. High sensitivity and specificity is achieved by doing a multiphasic CT scan, where there will be an uniform early arterial phase enhancement. All these hemangiomas are supplied by a branch of hepatic artery. All right. Second part, this is a very important for a short note. It is a, I don't know why examiners like that. This is the most uninteresting part. This is called focal nodular hyperplasia, or FNH. This is the second commonest benign liver tumor. It is also more frequent in females, and the frequency is even higher. Hemangioma was 3:1. Here it goes about 5 to 6:1. This focal nodular hyperplasia is not actually a tumor. It is, as it mentions, it is the hyperplasia of normal hepatocytes, and thereby it usually forms like a nodule inside the liver. Eta jodi liver thake, usually at the margins or near the edges, and often they are solitary. Architecturally, it is very difficult, even on microscopy, to differentiate between a normal liver parenchyma and focal nodular hyperplasia. But it can grow very big. So when they become very big, they can be palpable per abdomen. How will you, on those 2 points, that whether there is any malignant transformation and spontaneous bleeding. Malignant transformation doesn't happen, spontaneous bleeding doesn't happen. But regarding this malignant transformation, you must remember that focal nodular hyperplasia histologically looks very similar to a special kind of hepatocellular carcinoma that is called fibrolamellar hepatocellular carcinoma, FLC bole. So the histopathologist needs to be very cautious before stamping a patient as focal nodular hyperplasia. But if it is focal nodular hyperplasia, it does not transform into any malignant tissue. But its histological features are very similar to that of a fibrolamellar hepatocellular carcinoma, which is carcinoma at the very beginning. And how will you diagnose? This is very important. The diagnosis is usually made by a multiphasic CT. When you will write, I was going through the papers. If examiner asks you, or a theoretical long case, not long case, answer scripts, that what investigation will you do for carcinoma stomach, you just write ultrasound, X-ray. It is not like that. You must mention what you are going to get from that particular investigation for that disease. So that is why in multiphasic CT, when you do the CT to diagnose focal nodular hyperplasia, there is a core and there is a periphery, and there are multiple septa that goes like the spokes of a wheel up to the periphery. And when you do a multiphasic CT, the early enhancement happens at the periphery, and this the core that is there, that also become enhanced. Enhanced means when you give contrast on CT, it becomes more prominent, more whitish. So the core enhancement and peripheral enhancement, later they merge. That is focal nodular hyperplasia. This is very common in female. This is very important short note. I don't know why, but focal nodular hyperplasia, you will do it. And it usually presents as a solitary nodule, small nodule, but can be large and multiple. Usually happens near the edge of a liver margin. Often become very big to be abnormally palpable. It does not bleed spontaneously. It does not transform into a malignant tumor, but it poses a challenge to the histopathologist to differentiate between focal nodular hyperplasia of liver and fibrolamellar variety of HCC. Now, hepatic adenoma. You remember, when somebody says hepatoma, it means hepatocellular carcinoma, nor hepatic adenoma. Hepatoma means hepatocellular carcinoma, not hepatic adenoma. Hepatic adenoma is a benign tumor. What is the difference between hepatic adenoma and focal nodular hyperplasia? The macroscopic findings are more or less the same. Only thing in hepatic adenoma, within the tumor, you will not find any bile duct. Branches of the bile duct in histology. Clinically, it is very difficult. And hepatic adenoma, as I said before, it is even more common in female gender. The ratio is very much skewed in favor of the female, 10:1. It has got a direct relationship with the oral contraceptive pills. So, because the oral contraceptive pill, especially the earlier ones, they used to contain lot of synthetic estrogen and progesterone. Nowadays, they are reduced in amount, but you must remember this hepatic adenoma is dependent on estrogen and specially related to the prolonged use of oral contraceptive pills. When will you treat this patient? When the size of the tumor becomes more than 5. You understand, when the size of individual tumor is more than 5 centimeter, then you must treat the patient. And when the tumor does not regress on stopping the oral contraceptive pills, in that case, you should treat the tumor. Why it is to be excised surgically? Because as I said before, it does not bleed spontaneously, but it does have got a propensity to change into a malignant tumor. So it is a potentially pre-malignant condition of the liver. Diagnosis is again by multiphasic CT scan. Now let's go to the malignant tumor. This is the part that probably you people focus, but I will request you, if you spend 5 hours in reading the malignant tumors, spend at least 1 hour for reading about the benign tumors, because it is the benign tumors that comes more commonly as short notes, especially the focal nodular hyperplasia. So you must read that. Now regarding these malignant liver tumors, as I said before, of all the tumors, benign, malignant, the secondaries in the liver is the commonest tumor. But we will divide into primary tumor and secondary tumor. So first go to the primary. Primary tumors are mainly two. I have forgotten to write one there. The one that I have not there in the slide, you must remember, is cholangiocarcinoma is the third variety. So your focus will be on the HCC or hepatocellular carcinoma. Hepatocellular carcinoma, why it is important? Because it is a disease. Most of the carcinoma, like carcinoma stomach, carcinoma lung, the incidences are going down. But here I am talking about the West, because the statistics are only available for the Western countries. Hepatocellular carcinoma, on the other hand, the incidence is rising. The incidence is rising because of the epidemic of the hepatitis C. Whenever there is hepatitis C infection, a percentage of this hepatitis C sufferer will ultimately land into hepatocellular carcinoma. That is the usual way of dying for hepatitis C patients. So it is very common in the black African Americans. It is pretty common. And the incidence is threefold more than that of the native whites of America. Second is, demography. Age group, it usually happens in the 5th and 6th decade of life. That means in the more or less elderly patient. And the incidence is rising because of the hepatitis C infection. In about 85% of the patients of HCC develop in a liver which are cirrhotic. So most of the hepatocellular carcinoma, that is 85% of the patient of hepatocellular carcinoma, develop in a diseased liver. And the disease is usually a cirrhosis of the liver from any cause, of which, but on the other side, suppose what percentage of cirrhosis patient will develop hepatocellular carcinoma? That's not very high. 4 to 5% of the cirrhotic patients will develop hepatocellular carcinoma, except when the cirrhosis is caused by a specific condition, that is called, when cirrhosis is caused by iron deposition, that is called hemochromatosis, then the incidence of developing hepatocellular carcinoma is 10%. So two things you must remember, that hepatocellular carcinoma mostly happen in the diseased liver, 85% develop in the cirrhotic liver, but of the cirrhotic patient, only 3 to 5% of the patients of cirrhosis hepatocellular carcinoma But when it is caused by hemochromatosis, the incidence is higher of 10%. All right, so that is done. Risk factors. As I said, whatever causes cirrhosis can cause hepatocellular carcinoma, but the most important risk factor is, of course, hepatitis C infection. So alcohol abuse can cause, ultimately land up in hepatocellular carcinoma. Any autoimmune disease that causes like primary biliary cirrhosis, they can also develop into cirrhosis and hepatocellular carcinoma. Now, if I come to the pathology and clinical manifestation, the most important clinical signs of hepatocellular carcinoma are: one is weight loss and the other one is weakness. So these two are the most important features. Something similar to when you will go through carcinoma cecum, there is asthenia, anemia, all these vague symptoms, anorexia. So very difficult to locate what is the cause. But when the tumors goes rapidly, it can stretch the capsule and can cause pain in the abdomen. And hepatocellular carcinoma is one carcinoma which can bleed spontaneously because of erosion of a vessel or when a part of necrotic nodule opens into the peritoneum, that can cause severe intraperitoneal bleed. Now, how will you diagnose? So you see, hepatocellular carcinoma is diagnosed. First is very important. A short note is given. The importance of alpha-fetoprotein in hepatocellular carcinoma. Hepatocellular carcinoma is one carcinoma when the alpha-fetoprotein is measured, and alpha-fetoprotein is invariably raised in case of hepatocellular carcinoma. But the fallacy is this: alpha-fetoprotein can simply rise when there is cirrhosis itself. So how will you differentiate between whether this rise in alpha-fetoprotein is because of a cirrhosis or cirrhosis associated with hepatocellular carcinoma? And that is when you need to measure the amount. Normal alpha-fetoprotein level is 20 nanogram per milliliter. Less than that is normal. But to diagnose hepatocellular carcinoma, the value of alpha-fetoprotein needs to be at least 200 nanogram per milliliter. When you get an alpha-fetoprotein that raised, even if there is cirrhosis, you know that the patient has already developed hepatocellular carcinoma. This is very important because I come to later on, you know, in every cancers we do surgery for, we always want to get the either a tissue diagnosis in some form, either a cytological diagnosis or a histopathological diagnosis, either an FNAC or a true cut biopsy. That can be done percutaneously, paroperatively, in whichever way. But this hepatocellular carcinoma is one carcinoma where you can go for definitive treatment without waiting for a tissue diagnosis in the form of an FNAC or histopathology. And that is why the value of this alpha-fetoprotein is very important. When you get a patient with alpha-fetoprotein level more than 200 nanogram per ml, whether the patient has got cirrhosis or not, the patient is presumed to have a hepatocellular carcinoma and to be treated as such without waiting for any tissue diagnosis. So this is one. This is important for your short note. And the second investigation is, of course, ultrasound of the abdomen. Ultrasound of the abdomen, it has got a very high sensitivity but low specificity. how it presents. I forgot to mention that usually they present in three forms. First form is the nodule. That means a small nodule, either solitary or multiple, in the liver. The second one is called, that means if this is the liver, this is a small nodule here. And the second one is called massive. That means this big. And that there is a third one, which I forgot right now. I will remember it and I will tell you. So the first one is massive, first one is nodular, second one is massive, and there is a third one that is in the pathology I forgot to mention. So clinical manifestation, I told you, and the diagnosis. And this diagnosis on ultrasound, you can differentiate whether it is a nodular one. Nodule can be multiple, small, usually less than 3 centimeter, and these are called the massive ones. They are very big. So simple ultrasound, because of low specificity, we always do an alpha-fetoprotein. Whenever there is a raised alpha-fetoprotein associated with an ultrasonic finding, usually they are hypoechogenic. The echogenicity that they measure in normal liver, these tumors are hypoechogenic. So, and then there is MRI. The importance of MRI, it is the diagnosis of choice. When in a patient has got cirrhosis, he usually have got lot of nodules there. Now this MRI can actually differentiate between a nodule that is caused by the hepatocellular carcinoma from a regenerative or dysplastic nodule that is inherent to the cirrhosis. That means MRI is the best test to diagnose the nature of the nodule in case of a nodular liver disease. That nodular liver disease may be simple cirrhosis, or it could be a nodular variety of hepatocellular carcinoma. For that, MRI is very important. But the diagnosis of choice is, of course, it is multiphasic CT. Now, what is the characteristic finding in multiphasic CT? We get early enhancement. That means, suppose this is the liver, you give the contrast, and in the arterial phase, that is the early arterial phase, it becomes very enhanced. The rest of the liver tissue will take up dye like this, but this part will be very enhanced. This is called early enhancement. And in the late phase, that in the portal venous phase, it is called washout. That means if this is the normal liver density, this part will be practically without any white thing. That means there is no contrast. This is very, very diagnostic of hepatocellular carcinoma. So the diagnosis of hepatocellular carcinoma is by multiphasic CT, where early enhancement followed by late washout. This third one is FLC, fibrolamellar, that will come later. So we have covered this one, and alpha-fetoprotein, MRI, multiphasic CT, and then the treatment. I mean, staging for theory you can write in detail, but you need not to know. The staging is followed as in other malignant disease, that is according to the AJCC. This is called American Joint Committee on Cancer. They actually devised this TNM classification, which is applicable for many cancers like breast cancers as everything. So it has got, when there is N0, M0, then the stages can be, depending on the size of the tumor, will be 1, 2, 3A, and 3B. When there is N1, M0, then it automatically becomes 3C. And when there is M1, then whichever be the T and N, it becomes stage 4. So on the basis of TNM's classification, we divide it. And then what are the treatment? Treatment of hepatocellular carcinoma is surgical excision when it is possible. Suppose if there is a tumor in the caudate lobe, it's very close to the inferior vena cava, there you cannot actually do any kind of excision, so it becomes inoperable at the very beginning. But most of the tumors, hepatocellular carcinoma has got a bias to happen on the right hemiliver of the right side of the liver, right lobe of the liver. So the surgical excision is the preferred treatment. Preferred treatment of the surgical excision. Surgical excision, depending on where the situation is, we remove the tumor with only 1 centimeter margin. That is adequate. That can take the form of a right anterior segmentectomy, sectionectomy, or any particular segment, but 1 centimeter of healthy tissue. And the second treatment, and possibly the best treatment, is, so this is called orthotopic liver transplantation. Orthotopic liver transplantation. This is very important tumor because because hepatocellular carcinoma develops in a part of liver which is already diseased. So when you do some kind of excision, the rest of the liver function becomes very low. But in case of an orthotopic liver transplantation, you remove the entire diseased liver and put in a live liver, so the prognosis becomes very high. Initially the prognosis were very low, but later on a criteria was devised in orthotopic liver transplantation. They are called Milan's criteria. That you need to know. Milan's criteria. That means if there is a tumor which is less than 5 centimeter, or when there is 3 tumors and the largest diameter is less than 3 centimeter. This is criteria is taken. When you take this criteria and do the liver transplantation, then 5-year survival rate becomes as high as 50%. When you do excision, the 5-year survival rate is around 40%, with 40 to 50% recurrence chance within 5 years. So the treatment of hepatocellular carcinoma is surgical excision when possible, 1 centimeter margin. When that is not possible, then best treatment is orthotopic liver transplantation. Why it is better? Because in case of an excision, you leave behind a liver tissue which is already diseased by cirrhosis, because HCC happens in cirrhotic liver. And there are certain other treatment options which are there. If a patient is not suitable for either transplantation or waiting for transplantation, then you can do local ablation. Local ablation can be done in any of these forms: radio frequency ablation, microwave ablation, or cryo ablation, of which radio frequency ablation is the preferred treatment. There is a probe there. Suppose there is a liver, there is a tumor, here is the skin. You put in a needle, under radiology guidance you put the probe inside and you apply the radio frequency. It raises the temperature to about 60 to 100 degrees Celsius and it destroys the tumor. This is a very good treatment for those patients who are waiting for transplantation. And the last one is called transarterial chemoembolization. That is called TACE. That is also applicable for those patients who are unsuitable for surgical resection, to give a reasonable good disease-free survival. And I will say that fibrolamellar variety of hepatocellular carcinoma যেটা আমি বলেছিলাম, hepatocellular carcinoma, unlike the benign tumors, is more common in male patients, normal HCC. But in fibrolamellar variety, that preference for male is lost. That means it happens in equal frequency between female and male. Hepatocellular carcinoma, I said, happens in the 5th and 6th decade of life, but in fibrolamellar variety of hepatocellular carcinoma, it happens in the younger patient in their 20s or 40s. And fibrolamellar variety has got a better prognosis. Hepatocellular carcinoma is one of the worst cancer in the body, but fibrolamellar variety has got a disease-free survival 5 years up to the extent of 70%, which was 40% for HCC. And as I said, most of the hepatocellular carcinoma happens in diseased liver, mostly cirrhosis. Fibrolamellar variety usually happens in healthy liver. So when you read about HCC, you read a little bit about fibrolamellar variety of hepatocellular carcinoma.